Hello, everyone. Good morning, and welcome to the first Fireside Chat of the year. Today's session is in recognition of Cervical Cancer Awareness Month. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our team's mission is to reduce the burden of cancer by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, the importance of screening and early detection, treatment options, survivorship, as well as clinical research opportunities. My name is Amna Hussein. I am the Community Outreach and Engagement Manager on our team, and I will be moderating our Fireside Chat today. Cervical cancer, once one of the most common causes of cancer death for American women, has seen drastic changes in its prevention, detection, and treatment, thanks to ongoing research and medical advancements. In today's Fireside Chat, we will explore some of the latest and most promising developments in the battle against cervical cancer. It is with great pleasure that I introduce our esteemed guest, Dr. Colleen Rivard, a distinguished gynecologic oncologist and researcher at the University of Minnesota. Dr. Rivard has been at the forefront of groundbreaking research in cervical cancer, dedicating her career to improving outcomes for patients through innovative treatments and clinical trials. Dr. Colleen Rivard specializes in the treatment of adult patients with cervical, ovarian, uteral, vaginal, and vulvar cancers. Her research is focused on minimally invasive and robotic surgery, as well as surgical outcomes. Alongside her clinical work, Dr. Rivard is also an assistant professor in the Department of OBGYN and Women's Health at the University of Minnesota Medical School. Dr. Rivard is deeply committed to the care of women with cancer and believes strongly in involving patients and their families throughout the treatment process. She is dedicated to outcomes-based clinical research and often encourages patient participation in clinical trials to enhance the care provided to all women. We are so honored to have her join us for the special Fireside Chat today. So before we get started, I want to cover just a few housekeeping items. We will be recording the session today, so you can always refer back to the recording on the Masonic Cancer Center's YouTube page. Please share it widely with folks who you think might benefit from the session or are just interested in learning more. I would also like our audience to get familiar with using the Q&A feature, which is located on the bottom bar of your Zoom window. Throughout today's program, we encourage you to actively engage, ask questions, share your thoughts, reactions, and comments using the Q&A feature. We will have plenty of time for discussion following Dr. Rivard's presentation. For University of Minnesota employees and spouses participating in the University of Minnesota Employee Wellbeing Program, I'm going to put a link in the chat shortly to complete the survey to mark your attendance today. All right, without further ado, I will pass it over to Dr. Colleen Rivard. Dr. Rivard, the virtual floor is all yours.
Thank you very much. Appreciate this introduction. I'm gonna hopefully share this. Let me just see if I can do it in presentation mode here. All right, so if I do presenter view, are you guys seeing?
We don't see your slides.
You don't see anything?
No, just your presentation slides.
Just okay. I'm just making sure it's working right. Okay. So thank you. I was honored to be invited to talk here today about cervical cancer. This is hopefully the worst picture you'll see, but one of a specimen that we removed in the OR the other day. So I have no disclosures. I have no conflicts of interest or anything really, especially as it relates to cervical cancer. So the goals for today are to discuss the risk factors for cervical cancer, some of the common symptoms that women experience when they're diagnosed with cervical cancer, talk a lot about screening and prevention, because I think that's really the most important piece here, is that we have ways of preventing and screening and finding cervix cancer early, so that hopefully we are able to eradicate cervical cancer. We actually have the ability to do that now with some of our vaccines. And then we'll get into treatment and then clinical trials and patient resources that are available through the University of Minnesota and beyond. So briefly, cervical cancer is the third most common gynecologic cancer in the United States. Worldwide, it has a much higher disease burden. In the United States, there's around 11,000 new cases annually and around 4,000 deaths. In Minnesota, what that means is in 2020, which is when we have the most recent statistics, and I'll put the caveat that was COVID year. And so we are seeing evidence that there was a delay in diagnosis. So actually these numbers are probably lower than they are in other years. But in Minnesota, we saw 134 new cases and 43 deaths. We also know that it affects women of color and minority women more so than white women for many reasons. Unfortunately, we see higher mortality in Black women and a higher incidence in our Hispanic and Latino women. You can see it is a cancer that affects younger women. So the peak incidence is actually in your 40s, whereas a lot of our other gynecologic malignancies would be over here in the 60 or 70 year age range. Luckily, we do have good screening. And so you can see in the top left there, the mortality rate for cervical cancer from the 1950s to the present has decreased significantly, which is very reassuring. But like I said before, we do have the ability to make that zero. And so our hope is that we can continue to drive that mortality rate even further. On the bottom, the map of the United States, that's just a snapshot sort of the rate of cervical cancers diagnosed throughout the country. The darker the state, the more cases of cervix cancer. So you can see in the South, they have much higher rates of new cervical cancer diagnoses. There's a lot of complex factors that play into that, but a lot of that has to do with public funding for screening and prevention programs and how much is covered by state-run insurance. And you can see Minnesota does really well. We have a we're in the lowest sort of brackets in terms of rates of new cervical cancer. So that's a great thing for living in the state of Minnesota. There we go. Getting into risk factors, by far the most common risk factor for development of cervix cancer is the HPV virus. We know that HPV is responsible for 95% of all cervical cancers that are diagnosed. There's many different strains of HPV. The most high risk, though, or the most common that we see are HPV 16 and 18. And we'll get more into this later, but there is a vaccine that is directed at the HPV virus, and that includes 9 of these high-risk types of HPV. And then lower on the list of risk factors, because really these risk factors kind of work in combination with an HPV infection. So you still have to get HPV, but if you are a smoker, you're much more likely to develop cancer and much more likely to die from cervix cancer if you are to get it. So tobacco use is definitely a risk factor. And then women living with HIV or in an immunocompromised state are more at risk for developing cervix cancer once they get the HPV virus, and also struggle with higher death rates as well. So how knowing that HPV is critical to developing cervix cancer, how do we get from one to the other? And this is sort of a very simplified schematic here. You have a woman who contracts HPV, and it is sexually transmitted, but it's not truly a sexually transmitted disease in the sense that high risk behaviors put you at risk. Pretty much everyone who's sexually active throughout their lifetime will contract HPV at some point. So once you contract HPV, the vast majority of women are able to clear that infection, and the HPV infection regresses. But while you have that HPV infection, we see changes in your pap smears or on biopsies, what we call low-grade changes, or CIN, cervical intraepithelial neoplasia 1. And then those mostly regress. There's a subset of women, however, who are not able to clear that infection. And again, those other risk factors, smoking, immunocompromised state, we know can contribute to an inability to clear that HPV infection. But there are women who don't sort of have the traditional risk factors, and for whatever reason are continue to harbor HPV. And that then can progress to a high-grade lesion or high-grade dysplasia, CIN 2 to 3, or an adenocarcinoma in situ. And those are precursor lesions to development of cancer. From the time you get those high-grade changes to the time you get cancer is, in general, order of 7 to 20 years. It's a long time. And so that's why screening works so well, because we're able to catch it in that precancerous stage, treat it before it progresses on to cancer. So just to give you a sense, if someone has that high-grade dysplasia, left untreated, you have a 30% chance of developing invasive true cancer in the next 30 years. Contrast that with a woman who is undergoing routine screening and we're able to find that precancerous lesion. A treated CIN lesion has less than 1% chance of developing cancer. So it's really important that we get women proper screening and adequate treatment once they are screened. I just want to take a little bit of time to sort of take a side track here to talk about HPV and cancer in general. So I think it's pretty well publicized that HPV causes cervical cancer, but what a lot of people don't know is there's many other cancers that are also caused by HPV. And in fact, cervical cancer is no longer the #1 HPV-associated cancer in the country. Oropharyngeal, so head and neck cancers have surpassed cervix cancer as the #1 HPV-associated cancer in the United States, and that number is growing. Some of the other less common cancers, anal cancer, vulvar, penile, and vaginal cancer, are also highly associated with HPV. So I think just for context, knowing that when we get into the talking about the vaccine, you're protecting yourself not only from cervix cancer, but from these other cancer types as well. And that's why it's not a woman's vaccine. It's not a woman's problem. It's really a problem. HPV is a universal problem. So back to cervical cancer. There are several types of cervical cancer, but by far the vast majority of cervix cancer is squamous cell carcinoma. About 80 to 90% of our cervix cancers that we see are squamous cell. The next largest group is adenocarcinoma. About 10 to 20% of our cervix cancers are adenocarcinomas. Adenocarcinoma is a little bit more challenging. It can be harder to diagnose, and with some of our older screening techniques, with just pap smears, we tend to miss these adenocarcinomas more so than when we use HPV as a screening technique. And then there's adenosquamous, and then some very rare forms, sarcomas, neuroendocrine, again, HPV independent types of cervix cancer, very rare. And then for women who were exposed to DES in utero, there's a specific type of clear cell cervical cancer that is quite common in those women. So luckily, we have had a screening available in the United States, in the world, for many years. So in the top there is George Papanicolaou, and everyone's probably heard of the pap smear. We've shortened that Papanicolaou to just be the pap smear. So he sort of was the first one to develop this screen, which is basically we use a brush with we do a speculum exam and use a brush. There's many different types where we gather some cells from the cervical tissue, smear them onto a slide, and look under a microscope. There's been quite a few iterations and improvements on sort of his first pap smear. But for all intents and purposes, it's still that same looking at cells under a microscope. Unfortunately, the sensitivity of a single pap smear test for picking up a cancer is only 50 to 80%. Now, the more often you have those and the more frequently you do them, that sensitivity for picking up a cancer does improve. More recently, on the bottom, that's Harold Zerhausen. He's a German virologist, and he is the person who sort of discovered the role of HPV, human papillomaviruses, in the development of cervical cancer. He actually won the Nobel Prize for that in 2008. And so since that discovery, we combined screening with HPV with the pap smear, and we'll get into this in a little bit. We are moving actually towards screening with HPV alone. So the sensitivity of the HPV test for diagnosing cancer is 95%, so much more sensitive than a pap smear. And like I said before, it's much more sensitive for diagnosing that adenocarcinoma. Some women are concerned about not having a true pap smear every year. As long as you're getting HPV testing, you don't need to be concerned. Actually, primary HPV testing is not inferior to pap smear testing. In fact, there's more and more data that it is actually better, and it is likely to replace the pap smear in the coming years. It is more cost effective. So we'll go to the next slide here. There are several different organizations that put out screening guidelines. So the ASCCP is the Society for Colposcopy and Cancer Prevention, Cervical Cancer Prevention, and then the USPSTF is the sort of United States screening guidelines. And then on the right there is the American Cancer Society screening guidelines. So you can see they are slightly different in that the ACS has sort of adopted primary HPV screening as its preferred method. And I know that the ASCCP will be heading there in the coming years as well. So take home is no one needs screening under the age of 21. And that is because of that, a few slides ago, that progression from the time you get HPV infection to the time you develop a precancerous lesion is many years. And so most women in that time will be able to clear the HPV infection before it becomes a problem leading to precancerous lesions. From the age of 21 to 29, there's a bit of a difference in the ASCCP guidelines versus the ASC guidelines. The ASCCP recommends a pap test alone without HPV testing every 3 years. And the American Cancer Society breaks it down into 21 to 24, they recommend no screening. And from age 25 to 29, they recommend primary HPV screening every 5 years. And then that would continue until age 65. There's actually no difference between age 25 and 65 for the ACS. For the ASCCP, their recommendations are similar to the ACS, except that right now the recommendation is for a pap smear with HPV co-testing every 5 years, with primary HPV screening recommended. And then both still say that a pap test alone every 3 years is acceptable, but it is definitely not as effective. And then over the age of 65, you can exit screening with several caveats. Number one, you have to have had adequate screening prior. So if you're someone who doesn't have pap smears until the age of 62, you're not someone who it would be safe to discontinue screening at the age of 65. You need to have adequate screening. And what do we mean by that? We mean within the past 10 years, you need to have had at least 2 consecutive negative HPV tests or co-tests, or 3 consecutive negative pap tests at the appropriate intervals. And the preferred, again, is that HPV testing. So on top of adequate screening, you also have to have not had a history of CIN2, that precancerous or more, in the past 25 years. And then again, women that, exposed to DES in utero, and then those with an immunocompromised state, also not appropriate to exit screening at age 65. If you have had a hysterectomy where your cervix was removed, and this is something for women to be really educated about, if you're having a hysterectomy, what is happening with the cervix? Are they leaving it? There is something called a supracervical hysterectomy, sometimes called a partial hysterectomy, not a medical term, but that's sometimes how it's referred to, where the cervix is actually left in place. If you have a cervix, you must continue to follow the screening guidelines. But if you had a hysterectomy and you have not had any of that precancerous lesions found, then you do not need pap smears anymore. So how do we screen? We do the pap smear, and once we do the pap smear, we then move on to what's called a colposcopy. And so we do that again with a speculum exam, and there's a microscope that is used to visualize the cervix and look at those cells up close. There are several different types of changes we're looking for when we're using that colposcopy, and we will do biopsies of those different areas where we see those concerning findings. And if those biopsies show precancerous lesions, there's several options of how to treat that to hopefully help that precancerous lesion regress. Common procedures are a LEAP procedure, a cone procedure. Both of those are excisional procedures. So you can see in that picture, a cone truly is, just like it sounds. We sort of, with a knife, cut a cone out of the cervix and remove those precancerous areas. A LEAP is similar to the cone, except that we use a cautery instrument to remove that tissue instead of a knife. And then cryotherapy has fallen out of favor a bit in the United States, just because we have ready access to cone and LEAP, but definitely around the world is still being used. It's basically a freezing of those cells in the outer cervix there in order to treat those precancerous lesions. The ASCCP puts out a wonderful there's an app that you can use. Anyone is able to download it, where you put in just a bunch of risk data. So your age, HPV status, whether you've had previous screening, and whether you've had previous abnormal pap smears or documented precancerous lesions. And then it will give you a recommendation on what's recommended. Is it colposcopy? Do you need to go straight to treatment? And it will sort of work you through that each step of the way. It will then recommend, when do you need your next screening pap smear and HPV performed. So in the future, there are going to be significant changes, I think, coming up. There's a lot of people working on home self-HPV testing, so doing a swab on your own at home, bringing it into the lab, because I know for a lot of women, that pap smear exam coming into the clinic and having that done can be intimidating or uncomfortable for women. And so having the option to do it at home would be a wonderful progress. There's also some additional diagnostic tests that we may use to sort of triage women who need to go straight to an excisional procedure like a LEAP or a cone versus those that can be watched. So P16 and Ki67 staining, HPV DNA methylation. Those are some of the things we're looking at to see, can we sort of triage women. And then a big question is, in women who've had appropriate vaccination on schedule and are fully vaccinated, do we need to screen them as frequently? Can we space that out? Can we do it in a different way? We know that in areas where there's high uptake of HPV vaccination, we've seen a 90% decrease in high-grade dysplasia, so that precancerous lesion. So we know that it works. What we don't know yet is how can we change screening for women who have been adequately vaccinated. So this is, if you remember one thing, it is this: there is a vaccine that prevents cancer. Going back to my previous discussion on HPV-associated cancers, yes, this vaccine prevents cervical cancer, but it also prevents anal cancer, oropharyngeal cancer, vulvar, vaginal, and penile cancers. So this is an amazing breakthrough that we've had in the last 20 years, and I can't stress enough how important it is for young people, but also people who have not been adequately vaccinated to hopefully catch up. So the recommendation is for children between the ages of 11 and 12 to get the vaccine, but you can get it as young as 9. It was approved down to age 9. It's recommended for up to age 26 if you are not already vaccinated. And more recently, it's been approved up to age 45. So there are a lot of women who are sort of catching up and getting vaccinated in their 30s and 40s. We do know that it's less effective the older that you get it, but it's not ineffective. And so I would still recommend it for anyone up to age 45. So we prevent cancer by getting vaccinated and then also catching those precancerous lesions and treating them appropriately. There's a little schematic here. I think this is just a nice snapshot of what progress we've made. So HPV was first cloned and discovered in cervical cancer tissue in the early 1980s. And then the first HPV vaccine it was first approved for women, was approved in the 2006, which was, not even 20 years ago. And since that time, there's been several new vaccines with more HPV strains included. And then looking ahead, the WHO has an initiative to reduce the cervical cancer mortality by 90% by the year 2070. And there's sort of a mid-milestone there in 2030. We hope to eliminate it from low poverty communities within the United States by 2030. So those are sort of our targets and our goal and where we're headed. Again, if you take nothing else away, take this, that there is a vaccine that prevents cancers, both in men and women. And so the younger you can get it, the better, but anyone up to age 45 who has not been vaccinated, you can be vaccinated and decrease your risk of getting cancer. That's pretty amazing, if you ask me, that we have developed a vaccine that prevents cancer. I think there's a lot of people in their 50s and 60s who would never have thought that would be possible. So looking at, does the vaccine work? We know it works. And unfortunately, in the United States, we were somewhat of late adopters in terms of fully vaccinating large groups of children. But if you look, this is data from Australia, where they did a very good job of vaccinating everyone. And if you look at, the different colors represent different age groups. But if you look at people who are vaccinated less than age 20, that's that purple line, it significantly drops the rate of women who are getting cervical cancer. So really, really important. Just another note that HPV vaccination for unvaccinated women who have that precancer CIN3 can decrease the risk of recurrence of that precancer by up to 60%. So we do recommend that any unvaccinated patient who gets diagnosed with cervical precancer at 45 years of age or younger does get vaccinated. The vaccine, again, is intended as a prevention, but there isn't a requirement by the FDA to prove that you're HPV negative or that you don't have dysplasia. And so we do recommend that vaccine because it has been shown to decrease the risk of recurrence. So this just shows once you develop cervical precancer CIN3, at 5 years out, it's affected by whether or not you've been vaccinated or not. So if you've been vaccinated, your risk of CAN3 or greater is less than 1%, versus women who have HPV or are HPV positive with an unknown history. Their risk of CAN3 is, on the order of 5 to 12%. So moving on to actual patients who have cervix cancer, what are the symptoms? And unfortunately, early on in that precancerous stage and even early cervix cancer, there really aren't a lot of symptoms. And this is why primary prevention and screening are so important, because there aren't early warning signs with this type of cancer. Now, once cervix cancer is advanced, most women have some form of abnormal vaginal bleeding, especially postcoital bleeding. Other women have vaginal discharge, can be malodorous, can be watery. There's lots of different iterations of vaginal discharge that we can see in women with advanced cervix cancer. As it progresses, a lot of women do develop pelvic or abdominal pain, or changes in their bowel or bladder habits. That tends to be in very advanced stages where it has grown to a point where it's affecting the bowel and bladder, which are very close to the cervix. All right, so getting into cervix cancer itself. So stage 0 is that carcinoma in situ, or that precancer. The survival from that is 100% if treated appropriately. So again, that's why screening is so important. You catch it at that early stage before it has turned into a cancer. The vast majority of cancers in the United States, luckily, about 50% are stage 1 at the time of diagnosis. And that means that it's confined just to the cervix. When treated appropriately, 5-year survival stage 1 cervical cancer is 85%. So pretty good, not as good as we'd like to see it. That's why we're continuing to study the best ways to treat it, but still better than a lot of cancers. Stage 2 cervix cancer, still about 30% of women are being diagnosed at stage 2. Stage 2 cervix cancer has moved past the cervix into the vagina or the uterus, but not out to the side walls of the pelvis. Stage 3, about 20% are diagnosed at stage 3. This cancer has progressed past the cervix down into the lower portion of the vagina, or out into the side wall, where it starts affecting the blood vessels and the ureter. The ureter is a tube that connects the kidney and the bladder, and we can see blockages of that in stage 3 cancer. Unfortunately, 5-year survival for stage 3 cervix cancer is only about 35%. So we really, the higher the stage, we really struggle to truly cure women. And stage 4, stage 4A is a locally advanced, so it's invading into the bowel, the bladder at that point. Or there's stage 4B, which is distant, so metastasis in the lungs, lymph nodes outside of the pelvis that we see. And unfortunately, survival is less than 10% once we reach a stage 4. Right. So treatment, this is sort of a somewhat simplified schematic, but I think that it's really helpful. On the left, going from the left to the right is sort of the lowest risk to the highest risk disease. So again, if we are able to find it at the precancerous stage, it's a pretty easy treatment. We do a cone, a LEEP, cryotherapy, sort of excisional procedures to clear that precancerous area. In early disease, so those women who we are able to find it early enough where it's just in the cervix, those women we often treat with surgery. And then a subset of those women will require adjuvant treatment, usually with radiation, depending on risk factors that we have. And then once it's advanced past the cervix, we know that surgery is no longer a feasible solution. And so most of these women end up getting treated with a combination of chemotherapy and radiation therapy. And then if it's metastatic, sort of beyond the pelvis, women need chemotherapy or some of the newer treatments combine chemotherapy with some of our newer immunotherapy agents as well. So going into a little bit more detail, early stage treatment with surgery. At very early stages, there are a subset of women who can qualify for just a traditional hysterectomy, but the vast majority of women with cervical cancer who are candidates for surgery undergo what we call a radical hysterectomy. And what that means is not only removing the uterus and the cervix, but the parametra. So in that bottom picture, you can see there's sort of tissue along the side of the cervix there. That's called the parametra, and we know cervix cancers tend to spread sort of from the inside of the cervix out, and so removing that side tissue helps us determine has it spread to that side tissue. And then we also take the upper portion of the vagina, because we know that the vagina is also one of the first areas that these cervix cancers can spread. And so with that, there's more side effects and complications that can happen from that surgery as opposed to just a general hysterectomy. For women who are hoping to preserve fertility, there are some women who would be a candidate for what's called a radical trachelectomy, where we remove the cervix, that side tissue, the parametra of the upper vagina, but leave the uterus in place. So hopefully they can go on to have a pregnancy. With that procedure, you also have to place what's called a cerclage to sort of close off the lower portion of the uterus. Women who have undergone a radical trachelectomy and do get pregnant end up requiring a C-section for delivery. All women, again, also aside from a very small subset of patients who have very early cervical cancer, need to have some sort of lymph node sampling. So traditionally, we would remove all the lymph nodes in the pelvis and sometimes periaortic lymph nodes, but we've really moved toward sentinel lymph node sampling. All different parts of your body are drained by lymph tissue, and they drain in a very systematic way in a chain. And so the sentinel lymph node is that first lymph node in the chain of lymph nodes that's draining a certain organ. In this case, they tend to be in the pelvic region. And so we find that first lymph node and remove it. And the idea is that if there's cancer, if there's not cancer in that first lymph node in the chain, then there's very unlikely to be cancer further down the chain. And then there's options for leaving your ovaries, because again, women, the highest rate of cervix cancer is in women in their 40s, and so they're still premenopausal, and so it is often safe to leave the ovaries. There are some situations where we would recommend we remove the ovaries, but often it is safe to leave the ovaries in place. The route of surgery, this has been sort of a newer development in the last 5 years. There was a major trial that compared the route of surgery, so an open traditional incision versus minimally invasive surgery, so laparoscopic or robotic. And unfortunately, it showed that women who have minimally invasive procedures have shorter survival compared to the open. So it is really standard of care anymore to have an open traditional surgery. For advanced stage treatment, this is a combination of chemotherapy, generally with a drug called cisplatin that you get once a week, with external beam radiation, and then brachytherapy, which is internal radiation. You can see there's an example of a woman sort of undergoing that external beam radiation in the top corner there. And then the bottom here sort of depicts it's a very complex process how our radiation oncologists and physicists are able to develop a plan to sort of give highest adequate doses to the actual cancer itself while sparing as much of the normal tissue in that area. One thing to note is it is super important to complete treatment within 8 weeks and shorter if possible. And so we know that women do better when treated at an academic medical center that specializes in treatment of cervix cancer. They have better outcomes, better survival, because we're able to get it in the appropriate time. So whenever possible, we strongly recommend that women come to the university for their treatment for cervix cancer. And so that with the external, where you sort of lay on a table and get radiation, sort of like a CT scan or an X-ray. Brachytherapy, there's all different ways to sort of give a higher dose of that radiation directly to the cervix or the vagina. And these are sort of different instruments that we use to give that higher dose of radiation. Depending on the type of brachytherapy that you're getting, sometimes we're able to give it in an outpatient setting, but often it has to be given in an inpatient setting over about a week. And this is where we really see high rates of complications and toxicities. One thing I like to note is that we do see significant disparities in cervical cancer treatments and outcomes depending on where you live and where you get your radiation. So again, really want to stress that coming to the university or a place of high volume treatment is very important. I know this is a busy slide. It's not meant to for you to recall all of it, but once the cancer has spread sort of outside of that pelvis or it comes back, there are options for treatment, but not actually that many for cervix. And this is just a table of sort of all the recommended regimens of different chemotherapies and immunotherapies that you may see being used. Sort of a newer development in the last 5 to 10 years is sort of biomarker-directed therapy for all types of cancers. But for cervical cancer, there's several biomarker-directed therapies that are available. The first that we sort of discovered and have been using is PD-L1. Others, though, include HER2, MMR, MSI, the RET gene, NTRK gene fusions, and then we do sometimes use comprehensive molecular profiling to assist in giving us wider options for women who have progressed on previous sort of standard therapies. Again, a pretty busy slide here, not intended to recall all of it, but I just want to sort of point out, it's really incredible the breakthroughs and new options for treatment that we've had just in the last 6 years here. Prior to 2017, when pembrolizumab or Keytruda was sort of first approved for cervix cancer, we really had a couple traditional chemotherapy options, and that was sort of it. And so really in the last 6 years, there's just so many new and promising therapies that are being studied and being approved, which is wonderful. This slide kind of highlights that as well. This is a shorter time period from 2021 to 2024, what we expect to be coming in 2024 in terms of options for treatment. So some of these are already FDA approved, some of them are awaiting approval, but all really sort of exciting progress that we're making. So shifting gears to sort of what's available for patients at the University of Minnesota. Right now, unfortunately, we only have one open clinical trial at the university, and it's a surgical trial. So if you recall, I mentioned that there was a study that sort of showed worse survival for women who had a laparoscopic hysterectomy versus an open radical hysterectomy. And so this clinical trial is sort of doing a similar thing, but sort of fixing some of the problems with that first trial. There's a lot of people who believe that the reason women lived a shorter amount of time or had worse survival in a laparoscopic procedure was that that pneumoperitoneum was sort of exposing the cancer to that pneumoperitoneum was what caused sort of recurrences. And so the idea of this trial is that we're closing off the vagina below the cervix, and so the cancer is not actually exposed to the abdomen for that procedure. So we have that this trial open and available for women right now. Coming soon, there will be a phase 2 trial for recurrent or metastatic cervix cancer that's associated with HPV-16, as well as having that PD-L1 be positive. that has progressed after having prior treatment with pembrolizumab, and it'll be combining atezolizumab with a vaccine. So really interesting trial. And then finally, we have the DTC, or Developmental Therapeutics Clinic, which has phase 1 and 2 trials. And we have at least one solid organ trial that specifically includes cervical cancer. That clinic, the trials that are available in that clinic come and go pretty quickly. As with phase 1 and 2 trials, you don't need to enroll very many women on the trial. And so they often open and close pretty quickly. So that is always changing, but always a great option for women who sort of exhausted a lot of our standard therapies. I want to just make a plug for our HPV Center for Excellence, which is run by my wonderful colleague, Deanna Teo, who I cannot say enough about. It is developed and with the idea that it will treat all HPV associated at this time female pathology, as it's being run by gynecologic oncologists. So anyone with cervical, vaginal, vulvar, anal dysplasia, cancer, there is a plan to include patients with oropharyngeal cancers in the future, but as of right now, it's just female gynecologic precancer and cancers. The clinic is open in Edina, Burnsville, Maple Grove, and Minneapolis. There will be more locations to come in the future. And Dr. Teo is going to be opening HPV specific clinical trials, including hopefully several vaccine trials. So that's a really exciting new option available to women. The WHO has made it a 2020 goal to eradicate cervical cancer from the globe. And I think that's really exciting. You know, we've done that with other diseases. And I think now that there's a vaccine, we really do have the opportunity to sort of eradicate cervical cancer and the burden that it places on women. So more details there. And finally, there are a lot of resources. In the last 10 years, we've had more and more resources available to women. So I want to just point out Minnesota's SAGE program, which provides breast and cervical screening, as well as, if something is found, treatment options to Minnesota's uninsured and underinsured women. Survivor is a wonderful website. They have lots of patient education, patient advocacy. They fundraise. They do all sorts of things for cervical cancer. The Foundation for Women's Cancer and Society of Gynecologic Oncology, both sort of national organizations that treat all gynecologic cancers, but definitely a lot of information and money being raised for cervical cancer. And then I want to specifically point out At Your Cervix, which is a support group for women with cervical cancer, started by patients at the University of Minnesota, because they really saw that there was a need for support groups. So if you look, you know, in breast cancer, there's tons of things out there, tons of information, and there really wasn't much for cervical cancer. And so they started the group At Your Cervix. I think it's a very clever name as well. And there's a website and lots of information, and they get together and do a lot of advocacy work, and a lot of great work there. Finally, I just want to thank my partners, Dr. Deanna Teo and Dr. Britt Erickson, for their help and commitment to eradicating cervical cancer and having clinical trials open for our patients. And that is it. I'm happy to take any and all questions. So there's one question in the question box, so I'll start there, if that's okay. Is that okay?
Yep, feel free.
The question is, we talked about the importance of HER2 testing. How often are patients positive for HER2? And are these amplifications like breast? So it's not super common, and we don't have great data on how common it is, but it's not super common. But we do it exactly like they do in breast. So you start with IHC and then reflex to a FISH if that's positive.
Great. Thank you so much, Dr. Rivard, for that insightful and informative presentation. Your expertise and dedication to advancing the treatment of cervical cancers is truly inspirational. So I did want to put in a plug before we start questions, a plug for our cancer information line. So for anyone interested in learning more about current cancer clinical trials at the University of Minnesota, including Dr. Rivard's open clinical trial, please call the Masonic Cancer Center's Nurse Navigator line at 612-624-2620, or you can email ccinfo@umn.edu, and you can find this contact information on the Masonic Cancer Center's website. So just wanted to put that plug in because you mentioned it. But we'll go ahead and kick things off with questions. So please continue to submit your questions in the Q&A. I see some questions that are coming through. And we'll start with those. Yep. We'll start with those questions. So are there any links between endometriosis and cancer?
So that's a great question. The answer is yes, but not cervical cancer. So we know endometriosis is linked to several gynecologic cancers, but not cervix specifically.
So as an adult over 60 years old, is there a vaccine we should have had to prevent, I'm assuming, cervical cancer?
Yeah, so unfortunately, if you're 60, you sort of missed the window on when the vaccine was developed and FDA approved to when you can get it. So anyone over the age of 45, there is not a vaccine option at the moment. There are several ongoing trials nationwide sort of looking at using vaccines in women who have either precancerous lesions or cancer. So potentially in your lifetime it may happen, but as of today, as a 60-year-old, there'd be no vaccine that you would have been eligible for or need now.
Right. So as more questions come in live, there are some questions that were submitted through the registration that I'd like to ask. Are lesbian women more prone to getting cervical cancer?
No, they're not. Anyone who is sexually active and can contract HPV is at a similar risk of having cervical cancer.
Thanks for that insight. And then, I mean, on that note, do you still need a pap smear if you are not sexually active?
Yes.
Okay. All right. And then another question. So can you clarify a little bit more about why screening is no longer required after age 65? If someone contracts HPV at age 40 and it can take up to 30 years for cancer to develop, why shouldn't folks above 65 be screened?
So that's why it's super important that you have had adequate screening, including HPV testing, up to that age 65, because if you up to age 65 have not had HPV, the chances of you getting it and it turning into cancer, within your lifetime is very low. So, and the other caveat there is you have to have not had precancerous lesions. So, if you contracted it at 40, chances are you would have developed a precancerous lesion before 65 that we would catch if you're undergoing adequate screening. Does that answer the question, hopefully?
Thanks for that clarification. That was helpful. So I know that you stressed enough about the importance of screening and vaccination in preventing cervical cancer, but what other specific lifestyle changes or habits do you recommend to reduce the risk of developing cervical cancer?
Smoking cessation is the other big lifestyle change that you can make and you have control over. So smoking cessation, getting vaccinated, and adequately screened.
Perfect. So some other questions were just submitted. What new drug-based therapy are you most excited about? And do any have the potential of being the new standard of care?
I think because we know cervix cancer is caused most commonly by a virus, the idea of using immunotherapy is really exciting. Sort of using your own body's immune system to sort of attack that virus is really exciting. And I think definitely within hopefully my career, that will become sort of standard of care. And, you know, as with most things, we started studying immunotherapy and sort of recurrent disease where, you know, women were sort of out of other options, and we've slowly moved it up into upfront treatment. So it was recently approved to incorporate into upfront treatment for newly diagnosed cervix cancer. So I think it truly has the ability to really change the way we treat cervix cancer.
It's incredible to hear. Can't wait to just hear more about this in the future. So with some of the other cancers, we know family history plays a critical role. So for cervical cancer, is family history a risk? And if so, what steps can individuals with the family history take to proactively manage their health and prevent or reduce their risk of developing cervical cancer?
So that's a great question. And unlike most other gynecologic malignancies where there is a strong family history component, cervix cancer, because almost all are caused by the HPV infection, there is not a sort of a family history role in the development of cervix cancer. One small minor exception is that women exposed in utero to DES, which we're getting farther and farther from having women who would have been exposed because we knew about it and stopped doing that. So those women are sort of aging out, if you will. But aside from that, there really is no family history component.
Thank you for that clarification. So for patients and their families who might be navigating a cervical cancer diagnosis, what advice would you offer to them in terms of understanding treatment options and even participating in clinical trials?
I think getting to a cancer center of excellence, either at the university or another national comprehensive cancer center, is very important with cervical cancer, because we do a lot of radiation is involved. Radiation is one of those things where it's very important where you get it. It's not the same if you're not at a high volume center. The other piece of that is clinical trials are usually more commonly available through sort of national comprehensive cancer sites. So I would strongly recommend that women get treated at one of those sites.
Thank you. And we have time for just one more question before we wrap things up. So in your opinion, how can we improve public education and awareness about cervical cancer? So we'll wrap things up with this question.
I go back to it over and over again, the vaccine, and getting the vaccine out there. There was, when it first came out, there was a lot of stigma attached to being vaccinated against HPV. I don't really understand why, because it's just like many other childhood vaccinations. And so as much as we can make it available and make it just routine practice like all the other vaccines, I think that's when we're really going to see the rates of cervical cancer and death from cervical cancer improve.
It's a great way to wrap up our fireside chat today. So we are out of time, but thank you so much, everyone, for the engaging questions and for tuning in. And a special thank you to you, Dr. Rivard, for sharing your expertise and insight during the fireside chat today. And so again, we will drive this message home that because it is Cervical Cancer Awareness Month, this is the time to increase awareness, knowledge, and really just take proactive steps towards cervical cancer prevention. And I think from the photo that you have in your last slide, Dr. Rivard, that's from one of the public awareness campaigns that our state has done. And so it's lighting up our state monuments, teal for Cervical Cancer Awareness Month.
Teal is the gynecologic cancer color, so we love it.
Yes. And so after the session ends today, please, Zoom will populate a window to complete a really brief survey for us. We greatly appreciate if you could just spend a few minutes to provide us with your thoughts and feedback about today's fireside chat, because it really does help us continually improve our offerings. And after you submit the survey, don't close the window just yet, because there is a link for you to enter the drawing to win a prize pack filled with goodies from the Masonic Cancer Center. And this is just a small token of appreciation for completing the survey for us. And then also the link will be sent in the follow-up email that will go out tomorrow. And mark your calendar for our next Fireside Chat on Wednesday, February 21st. We'll be joined by University of Minnesota researchers Dr. April Wilhelm and Serena Zhang for a conversation on pathways to cancer prevention and strategies to address cancer disparities in cultural groups in Minnesota. And lastly, make sure you follow the Masonic Cancer Center on all of our social media platforms to stay up to date on future announcements and upcoming events from the Office of Community Outreach and Engagement. Thanks again, everyone, for joining our cervical cancer focused Fireside Chat with Dr. Colleen Rivard. We look forward to your continued engagements in future Fireside Chats and hope you have a wonderful rest of your day and week. Bye, everyone.
Bye. Thank you.